Good afternoon, everybody. Thank you for making time to be here for Delaware Breast Cancer Coalition's In the Loop. Today, we are having a presentation from Ray Beyor from Ray Life Coaching. Ray will explore how identity, relationships, and power dynamics shape healthcare for LGBTQ plus and polyamorous people facing cancer, chronic illness, and caregiving transitions. This session offers practical tools to honor identity, support chosen family, navigate high-stress conversations, and build confidence in care experiences. Led by Ray Beyor, a queer non-binary coach, participants believe with strategies for clearer communication, stronger connection, and trauma-aware presence in healthcare interactions. Thank you for being here today, Ray, and I am excited to have you, and I'm going to give you the floor. I'm going to spotlight you so everybody can see you.
Okay, thank you so much, Meredith. So I know there's a few people coming on as we talk right now. Again, this is about care without erasure, and I am a polyamorous, pansexual, non-binary, so I go by they them, coach, but also consultant and educator. And today we're going to go over navigating health on either side, whether it be family member, person going through it, or administrator or clinician, for people who might step outside of the standard societal norm, LGBTQ plus or polyamorous or anything else. And I wanted to first say, if you could not raise your hand, because I want you to put on the comments if you've been a patient or survivor of cancer, breast cancer, family member or caregiver, healthcare professional, and just write either one of these: patient, survivor, family member, or caregiver, healthcare professional in the comments, social worker or advocate, administrator or support staff, and community member. And just write what you've been in the past or what you are now or all of the above. And what's important about this question is that most of us have occupied more than one of these roles at some point in our lives. Um, at some point, we have needed care, and hopefully, at some point, we have provided some care. And today's conversation is not about whether or not you've been a patient or a care provider, but more it's about what happens when health, identity, and uncertainty, relationships, and power intersect or collide. And I'll just tell you a story of mine. I have personally not been diagnosed with any cancer. I thankfully, knock on wood right now, are somewhat healthy. But my history is that I've had many family members and a mentor when I was getting out of college. They were the person that pretty much helped me get into college from 13 into 18, passed from breast cancer right after college. And my grandmother passed when I was 1.5 years old from breast cancer at 53 years old. And my aunt had like at least two bouts of breast cancer, as well as other kinds of cancer in the past 20 years. So I'm guessing that if you aren't somebody who has been diagnosed in any way, you probably know somebody. And that's what this is about today, as well as dealing with people who probably step outside the norm. And I'm just looking at all the responses, and I can see that you probably all have a whole bunch of different experiences. So thank you for responding. I'm going to put on my slides, share my slides. So let's do that. Share. And you can see my screen. And how does that look, Meredith? Is she there?
Looks fantastic.
Okay, I'm just making sure because right now I'm like having a difficult time seeing it. Okay, so this is me. Hi again, Ray, Ray from Ray Life Coaching. I go by they, them. And again, speaker, educator, coach, and consultant for LGBTQ plus and polyamorous, but also people who are just struggling to be seen in some way, shape, or form and have the life that they want. And today we're going to explore healthcare versus care, the difference, attachment, communication and regulation, and how understanding these three principles will help you deal with not only your own care but also others.
At my
And
desk,
I'm Are
nothing
you
happened.
there?
Nothing to eat today. Okay.
Oh, let me, you,
Okay, and I'm going to provide you a tool. Actually, I'm going to provide you two tools, but one of them is the bias key awareness, and we'll go through that very quickly. Also, power dynamics and assumptions and how they play a role in not getting care. Identity, language, and visibility, body, trauma, and grief. And then the next tool will be the band key, understanding needs and how we can provide needs not only for ourselves in the moment, but also for the people that we love or are taking care of. Confidence during life change. If you're here, you can sign up for free for the Confidence Toolkit, which is the bias key, the band key, but also reprogramming of so that you can be fully there for yourself, but also for the people that you care about. Practical tools for everyday care. Okay, so now we're just going to start ahead. Um, Healthcare versus care. Let's begin with simply the distinction. Healthcare and care are not the same thing. And you can disagree with me, but we'll talk about it afterward. I'll give you some time to, with any questions or comments that you might have. But I'm just going to say that healthcare sometimes focuses on diagnoses or treatment, medication, procedures, outcomes, which is really important. But care can sometimes focus on the person, the dignity, the belonging, the identity, the safety of that person, the relationship that's happening, and what they have already coming with, emotional and well being. Healthcare can ask, what's wrong? And care asks, what, what really matters? Healthcare asks, what treatment is needed? Like, we want to solve a problem here, right? There is a problem. And care asks, who is this person and what support do they need specifically? And it might not fit this container that we're so used to seeing it. B, both are necessary though. But many people experience healthcare without experiencing care. And when I say healthcare, it can also mean that some of these providers that we get are our family members, our friends, come out at us in a way that, or even ourselves, where we're just trying to solve a problem, but we're forgetting about the entirety of our lives and what we come with. And when identity is misunderstood, invisible or dismissed, that gap often becomes larger of care, of having care and receiving care. So I wanted to just pause for a second and see if I can get off of my. Hang on, sorry. Like not finding the screen. Hang on. One participant.
it is not over here.
Is it? Is it
No,
not sharing?
no,
Did
it's
I
not.
dis?
I think you did.
Okay, so I did it. Okay.
You're okay.
I can't tell. So I wanted to just put it out to you all. What do you think about healthcare versus care? Is there anything that comes up for you? And if you want to put it in the comments or you feel brave enough to voice it, I'm open to hearing any comments about what comes up for you about care versus care. I mean, healthcare versus care.
There are some very talkative people on here who are not talking.
And that's okay. We can move on if
I
that's
have,
not
I,
like, go
I'm
ahead.
sorry, I have a comment. How are you? I'm Natalie. I'm with Delaware Breast Cancer Coalition. And I think
Yeah.
I'm just hopping on, so forgive me because I had to have an appointment, but I want to be on listening. But you're asking a really important question as we navigate with our constituents throughout their care journey. And I'll call it care journey, even though we're talking about healthcare, right? But their care journey, because from their perspective, yes, it's hair, it's healthcare, and it's something that they're dealing with. But care, I think, is their ultimate need, if I can say that. I found throughout life as a young adult and as an adult, when I had to navigate health issues, healthcare is provided. I was fortunate to be able to have healthcare, but what I sought most, and I still see it today, is the care part of it. And I think we are not there yet completely. I think the sentiment of training and being sensitive or sensitized, uh, it needs to be emphasized more. I think we have more desensitization in many cases because of familiarity. That means in the healthcare field, we're dealing with the same illnesses, the same diagnosis, and so we treat them all the same. So my opinion on it is that we need more specialization, more focus and concentration, whether we are the clinicians or working in the public with care and how to care. Um, and I'm not saying be overwhelmed in the sense of, oh, I'm so shocked and I'm so sorry for what's happening. You know, I mean caring for the whole individual. And that's just my comment on that. So,
Great. Thank you. Natalie, it was.
Yes.
yes,
Thank
yes.
you. Thank you, Natalie.
Oh, you're welcome.
I'm going to move on because we have only a certain amount of time, but at the end, I definitely want to make time for questions and comments. But throughout this, I will be asking of you anything that might come up. We might not have a ton of time for a whole bunch of people, but so I'm going to continue and share my screen again. Okay, so we talked about just the difference between care and healthcare. And I wanted to go into attachment styles and communication and regulation because I think this is where all of us, including myself, um, at, sometimes we're, like you said, Natalie, there's the familiar. There's this place where we step into a scene. And if it's either familiar or not, we might, if it's familiar, we get on this groove, right? We get on this space of this is what we do. And we kind of sometimes forget about what this new person or this new situation. Now, someone coming into something new, well, their nervous system gets taxed, right? So that means that whatever's familiar for them in relationship to their stress, they will then revert to that. And that's their familiar. So in my practice, I teach what familiar is. It's actually, for me, an acronym for how we deal with um, pretty much anything. But when we get most stressed is when it comes out, usually in a way that might not be what we want to be doing, and might be getting us the same result in a way that we would like to change. And so F stands for firsthand experiences, A stands for auditory experiences, and M stands for modeled experiences. So either you, right, as a care professional, or you as a person taking care of your health, you might find that you go into this space of what you're used to. And if you're stressed or not, you might revert to whatever you were taught to do. And this is where I want to kind of give you tools to maybe question some of that for yourself and look and have an exercise on hopefully a daily basis that you can go to so that when you do get stressed or when you do get into that box of the familiar, you go, oh, I see what's happening, and you can step yourself back. So I'm going to talk about attachment here first. One of the most overlooked realities in healthcare is that every person enters the room with a nervous system. And that's pretty much what I was talking about. So that includes patients, doctors, nurses, family members, administrators, and everyone else. And when stress increases, attachment patterns become more visible. And that's exactly what I was saying, especially with the familiar. If you group it with an emotional experience, obviously somebody who's getting some healthcare that's really scary, they're like really on the high emotive space in their body, right? Because it's so unknown. But if it's a repeat offense and then they've had experiences in the past that brought that feeling up in them, and it was repetitive, they might be also bringing in with them some trauma, some information of how they should respond, and it might not be in the best way. So knowing that and understanding that it's not just the moment, but also everything that you're coming in with. So attachment theory helps us understand how we seek support, trust others, ask for help, and respond to uncertainty. So attachment styles influence how people respond to stress and connection. I'm just going to give you a brief overview of this, and it might give you an idea of like where you stand and where you've seen other people respond. So an anxious person may ask many questions. They might seek reassurance. They might need a lot of hand holding. They fear abandonment and worry information might be missing somehow. An avoidant person, this is the second attachment style, minimize symptoms, delay treatment. They might not tell anybody. They avoid asking for help and insist they are fine. You might not even see that they have emotions. They might be very deadpan, seem very calm. That is actually a freeze response. So their body is actually shutting down and pushing everything down. Kind of the most dangerous in some ways. A fearful avoidant person may want support, but also mistrust it and also think that the information is, they are going to be noticing every detail. They'll probably be writing. They're very emotive. They're very expressive. They're going to ask for things, but at the same time, they might have a heightened response on the emotional spectrum as like more anger involved, move toward and away from connection. So you might find them just shut down completely at the same time. So, and providers have attachment patterns too. A clinician may become more directive, a caregiver may become overly involved, an administrator may become rigidly policy focused. That's kind of like the familiar you were talking about. And these are not character flaws. Often they are stress responses, and they helped us at one point really keep us safe. And often underneath there's underneath communication is regulation. So we need communication, but underneath that we need regulation. And underneath regulation is awareness, and awareness creates curiosity. Curiosity helps us ask questions instead of making assumptions. And this is actually the premise of this talk today is curiosity. And how do we use it almost in everyday circumstances so that we notice how we are assuming things underneath all of our care or how we take care of ourselves. So I wanted to do a reflection for you all that you could do right now. And I want you to ask, what am I carrying into the room? So let's make this personal. Think of a time when you felt vulnerable. Not necessarily medical, just vulnerable. Maybe it was a loss, a diagnosis, a conflict, a major life transition. And ask yourself, when I feel vulnerable, what do I tend to do? Do I ask questions? Do I withdraw? Do I become emotional? Do I become analytical? Do I try to fix things? And if you want, you can put it in the comments, raise your hand, tell me a little story. That is fine. I am open for that right now. Do you try to fix things? Do you avoid asking for help? Do you just take control? Let's solve this. Okay, so I see someone says I become emotional and try to fix things. Thank you, Mackenzie. Yeah, so knowing these things is so important, but also kind of if you're helping somebody else, you might see if you know them, if you've known them for a long time, you might see some patterns, right? Of like what happens when they're heightened. And what assumptions do, this is a question for you, what assumptions do you think you make when you're stressed? And just notice what comes up. Because whatever you noticed is something you bring into healthcare interactions, probably. Especially when things get heightened, right? Patients bring it, providers bring it, caregivers bring it, and administrators bring it, and we all do this. And I see Irani, if I pronounced your name wrong, sorry. I take control and try to see a positive even when I know I'm not honest with myself. Oh, yeah. And that can be slightly dismissive. These are things that we, try to cope, right? Where this is a coping mechanism. So I am going to share again. Okay, I want to get to, and we already did that. Sorry, I didn't show you this, but this is what we went through. I want to go through the bias process. So, this is a tool that I have in my confidence toolkit for coming out, but I think it's just relevant for pretty much everybody. It's something that I learned in order to deal with my family and deal with new things because coming out means realizing that, people aren't going to agree with you and they're not going to like you and they're going to stop talking to you. So, the process is it helps us identify what is happening beneath the surface before it starts driving our behavior, hopefully. The more you do it, the more you can start to pause. It'll help you pause. And I think that's the most important part of this. The bias key explores body sensations and emotions. So that's the B. And then ingrained beliefs, which tend to be the hardest thing to find. So we can leave that to the end. Automatic actions and stories. And let us use a patient example here. Your body, my stomach is tight. My belief, doctors never frickin' listen. Automatic actions. I stop asking questions. I'm just done. You know, the story. They've already decided. So I have no control. So the belief actually right here, the doctors never listen, is really a story as well. So if I were to say the belief here is I'm helpless, I'm hopeless, that sounds really horrible, right? And that is what is happening in your body. It's down deep. And it's really hard if it's a belief to kind of come up from that and do anything different. And that's why it's so important to have this information. So I'm going to do a provider. Their body, I'm feeling really like stressed out. I'm like rushed, anxious, a lot of nervous energy. Belief, I should already know what they need. automatic action. I interrupt them, the story. We don't have time for this. Okay, so again, the belief here is still a story. I should already know what they need. And what that tells me is that they feel like they're not enough, and there might be more to this, right? Like, oh, I'm unsafe, or so there are. I will provide you with this whole belief list because that's really important. It gets down to the crux or the root of what's happening for somebody. And it's so important because once we do that, then we can change it for ourselves. Okay. If you want in the comments, if there's anything that comes up for you on your own stress, if there's a story, if there's like a belief that seems to run or that you've seen someone else continue on, feel free to put it in the comments. This is helpful for not just me, it's not for me, it's for you, right? And for the people that are currently watching this. We're going to talk about power dynamics. I think this is really important because it changes everything, right? And you'll notice that I'm not specifically dealing with LGBTQ plus and polyamorous people per se, but it comes up even more because if you're outside of the norm, you're already down on the level of a lower power dynamic, as well as being in healthcare, right? You're looking for someone to tell you what to do, how to take care of yourself. And you're hoping that this person knows something. But at the same time, you also want to have agency. So healthcare contains unavoidable power differences, right? Providers hold knowledge, authority, access, documentation, and patients often hold vulnerability, dependence, fear, uncertainty. And when identity enters that picture, these dynamics become more complicated. Questions emerge like, will I be judged? Will my partner be respected? Will I have to educate everyone and do that emotional labor for them while I'm trying to care for myself and my family at the same time? And will my identity impact my care? Probably. And many discriminatory experiences do not begin with malice, of course. They begin with assumptions and probably a desire to care for each other. Many LGBTQ plus and polyamorous individuals describe illness as a second coming out process. And that is why I'm here. They must repetitively decide, who do I tell? Can I be myself here? How much do I disclose? Will I be safe? Will I be respected? Will I get the information I need? Or will they tell me the information for somebody they think I am? Questions that heterosexual, cisgender, monogamous individuals may never need to consider become daily decisions. And they happen while someone is already managing treatment, uncertainty, grief, and recovery. And on top of that, their life is completely altering. Yeah. Okay. So this is a lot on the screen, but you will get these slides if you want them. And I wanted to touch on intersectionality, will of privilege. And this is really great, right? Like, what are you coming into the room with? And what is the person coming into the room with? You might not know any of these things about them, but it is really good to think about because this will tell you how uncomfortable they may be feeling, or you, right? Because although you might be the caregiver or at a certain level, you might have some power there. You might be all the way on the outer circle for everything else, but they don't know that either. And you may assume that they're on the inside, the power side, the circle, but they might not be. So understanding that your privilege and your actually may determine a lot of the power that you have. And I've heard from my consent teachers that when you don't know how much power you have, you're the most dangerous. And you're probably the person who's taking, who's uh, not taking ownership or accountability for the power that you have and stepping over people and unconsensually. But that's the thing. Awareness is huge on this, right? So that's why this wheel is so important. And if you'd like to, you're going to get the slide. So looking at this is really important, but just kind of give yourself an idea of where you stand on this wheel and maybe where your friend or your family member or your loved one or the person you're caring for stands on this wheel. So like I said, LGBTQ plus people are coming out. And these are the questions that come out for them when they're getting sick. They feel like, okay, I have to do this again, you know. And I would say that that is probably the biggest stress that could happen because they're feeling like they don't know if they should tell people or if they think that their caregiver should know because it says it and it's obvious, but they're treating them in the opposite direction, then it feels really disrespectful. And then they're deciding on who is going to be there for them. So we're going to talk about language screening and invisibility. Consider the term breast cancer. Who sees themselves reflected in these words? And understanding that words that we use, sometimes we forget who they are for. Who are they? Who are they saying um, this is for? Right? Who's who doesn't see that as, oh, that's not for me. I don't have breasts. For for some people, right? Like their body in itself. Let's say, I'm just going to give an example, a person who is transitioning from a female body into a male body is maybe currently has breasts, female breasts, but doesn't want it, but has cancer. Their experience of this might be totally different. But again, you can't assume that either. So I would like to put curiosity in language for y'all. Some providers may take assumptions about anatomy, but I also think family members, friends, you might be like, oh my God, I can't believe you're gonna take remove your breasts and that person might be like, "Mm." It reminds me of somebody who said to me, so they were so annoyed when they told someone that they were divorcing, and the response was either or, right? It was either, oh, that's horrible, or oh, I that's amazing. I'm so happy for you. But instead, it seems like what's needed is a question. How is that impacting you? How do you feel about that? And that question, the language influences access and inclusion. When people don't see themselves represented, they are less likely to seek care. So if not only the language, but also being able to be seen in that way and not assumed, oh, you're either or. This isn't about really anything except for being able to see people for by asking the right questions or just asking a question that's open-ended and not assuming. I had touched on grief and trauma um, before, and a little bit. Cancer affects more than our tissue, right? It affects our identity. I can only assume, I haven't gone through it, but I can only assume that your life is just changing. It's going to change. I think about the people that had passed in my life from cancer and what they had to go through, but also the people who survived and how their life changed afterward and what choices they had to make during. They could no longer be the caregiver. It's very possible that they were the caregiver, or maybe they were the provider and they can no longer do that. Their life up it ends, right? But then we have sexuality, gender, your relationships, and who you want to be there for you, your self-image and what you come in, your confidence around that. And one person's reconstruction may feel empowering, like I said before, and another person's may feel devastating. We can't guess what that's going to be for a person. We can only ask. One person may be grieving a body part, and another may experience conflicting emotions around gender affirmation and loss simultaneously. Care begins when we stop assuming what somebody's body means to them. And there's, body holds the score, right? If you've heard of Gabor Mate's uh, books and studies. And that is very true. When things happen to our bodies, they're not only coming in with some trauma related to, and may not even know it. It might come up in droves because of a stressful situation, but also because they're dealing with pain or just having to expose something that's very vulnerable. So I want to and if you guys have any comments, if you all have any comments, I'm going to say oops to the guys because I no longer want to say that. And that is actually a lesson. I'm just going to go quickly to this little mini lesson about language. If for some reason you are talking to somebody who's not binary and you forget and you keep on calling them he or her, it is okay that right after you go, oops, I'm trying to change that. I know you're they. You know, the confidence that you have to have something to say after it is so important because you're taking accountability instead of skipping right over it. Skipping right over it is understandable. We all do it. I do it. I'm not very good at my own pronouns that I want to be using. And sometimes I'm not good at what I'm just teaching. But at least you now have something to do, right? Just say, oops, that was my bad. Let me say that right, you know, and own it. Owning it is great. Or being like, hey, actually, I don't know what pronouns you go by. That's really important. So language is important. If you find yourself moving into an assumptive direction, just backtrack a little bit by a little oops. That's fine. Be like, oh, no, that's on me. Okay, so we're going to go on band key. Band keys about, again, it just goes over your body sensations and emotions, automatic actions. So these are the things that might occur. And thank you, Jennifer, and you're welcome. Might occur if your body is responding to something, right? Your emotions are coming and you might have an automatic reaction. Just like the bias key, it's the same thing, but we're just moving it now into the needs of like, okay, let's say a patient appears angry. Maybe the need is agency, but we can't guess, right? This is, you can go, hey, I see some, and you can just voice it. I'm noticing some heightened voice, like your voice is escalating. Are you really upset? What's going on? What's going on for you right now? Are you needing some autonomy or agency? Your caregiver appears controlling. And maybe they're micromanaging, right? Or they're like getting really heightened about what you're supposed to do. And maybe the need is reassurance. Now, as the person who's getting care from a caregiver, you're also the caregiver's a service provider. It is important to be like, hey, while I'm getting care, this is a boundary. While I'm getting care, I'm needing my caregivers to recognize my agency. And however, I see that um, you're really good at your job, and you really know what to do, and I appreciate that. But I'm also needing room to breathe so that I can and slow it down so I can understand what my options are. So reassurance might come at one space with also caring for yourself. A clinician appears detached, and maybe the need is capacity. So they may need to kind of take a breath, give themselves some care, hold themselves with compassion. A family member appears demanding, and maybe the need is clarity. Maybe they're feeling really scared and they're feeling out of the loop, worried. Again, this comes into attachment styles. When you stop reacting to behavior and begin listening to the need, care may change a little bit because ultimately the bad behavior is there to serve to protect them. And they don't realize they are not aware or able to communicate for themselves and provide the need for themselves. That doesn't mean that you have to, but it does mean that you can see it for what it is, set your boundary, and also speak it and ask. So I'm wondering if any of this is resonating in this moment for y'all. If anybody is interested in speaking.
So, no one's speaking, but I will.
Okay.
I have a story like this because my husband, it's not breast cancer, that's why I'm hesitant, but it's prostate cancer, and my husband was diagnosed with it. So we're sitting in the office, and I know this is a long story, but we had to wait for his prostate cancer treatment because he was going through an intestinal reattachment surgery. So we had like a year where we delayed cancer treatments because he was trying to get well from a different ailment. And we sat in the office, and the doctor was giving us our everything you said. So, so very true. Our minds went blank. We came back. My husband, I looked at him at one point and realized he had absolutely turned off. I'm like, he is not even hearing the doctor. So I stopped. And here's
Mm.
where I became, what is it? What was it? Aggressive? The aggressive family member. That was me. So I began to ask for clarity. I began to ask the doctor, will you repeat those three options one more time? Because I'm not sure we understood them. And I will tell you that I only was able to do that because of where I work now and where I have worked before with medical people who told me, do not sit and be quiet and take notes or walk in with a pad, which I used to do, walk in with a pad and paper, but I just thought I was so hip now that I would be able to do it. Swear to God, midway through that doctor's speech, I had to stop him and have him go back. But in the end, we opted for a treatment right then that started right that moment. He could do something with some kind of shot. And we opted for it at that moment. And I think he was shocked that we made that decision so quickly, but we didn't want to delay treatment any longer. And
Mm.
my husband looked at me and I said, is this what you want to do? And once he said yes, we looked at the doctor, and the doctor kind of sat there, and we said, we're going to go forward with this. And again, he just sat there, and I said, could we do it now? And then he got up and moved. And it was almost like you have to I had to push him a little bit like, yeah, we're going forward with this. We're not kidding around. And it didn't look like at first it looked like he was a little shocked that we jumped. But then he was right on board with us. And truthfully, he was a great doctor for my husband. He did a great job. I really appreciated all the love he gave him, or they gave him. They took good care of him, and he's healthy today. and winning on all sides. All that stuff that was behind him, he got over it. But I will say everything you said happened in that first meeting with the doctor, the first cancer
Mm.
consultation, all those things absolutely happened. And I would have sat there like a lump, but I had been coached, really coached by other people that said, open your mouth. And when you don't know what they said, ask them to repeat it. And it worked. It was, so I'm going to say yes. Everything you said, been through it and didn't realize it was a scenario, that it was that it happens to a lot of people. And this is our reactions. So thank you.
Oh, you're welcome. And I didn't get your name. Who's speaking?
Jennifer.
Hi, thank you, Jennifer.
I keep raising
Yeah.
my hand, but I didn't realize I was off screen.
Oh, I didn't see the raised hand either. I apologize. Yeah, and it sounds to me that Jennifer's spouse, I'm guessing, Jennifer, that was your husband that you said?
Yes.
Yeah. Um, was going through a freeze response, right? And just not able to, like, just overwhelmed. And thankfully, you saw that and could be there for your partner. Not always is that possible, like you said, you were trained and coached. I mean, that's a little bit what this is about, is to understand if you practice a little bit of skills, it'll make it that much easier when stress comes at you. Because obviously, uh, everybody's different. All humans are different. And when you're in a health crisis or helping someone with a health crisis, if you're on that side of helping, you might think you know, but you don't know this person. So in each case, you are dealing with the unknown, and that in itself is stress. And so what comes is your attachment style and how you might respond. If you can provide yourself with a little bit of help beforehand on a regular basis, it will then kind of give you that pause like Jennifer had. Just having that pause is so important so that you can say it. Oh, I need a little pause. And also, as I give myself that, I'm noticing I'm needing more clarity. But it's very hard to do that when you're in your own fight, flight, freeze, or fawn mode. And then also noticing that the person you're caring for is also in that space. It is also okay, and I know probably very hard, but sometimes we can't do that in the moment. It's also okay to leave, to say, hey, I have to come back and reschedule. I mean, that sounds horrible, but sometimes that's what has to happen. Or, hey, I need to record this in order to, because my brain is just past the mode. Preparing yourself for those moments is a part of life, really. But as LGBTQ plus people and anybody outside of the scope, it's like an added thing, right? You might not even be able to feel comfortable having your spouse or partner or partners in the room, but you need them there. And you know that you're that person who's going to freeze. So, understanding that on the other side is being able to ask those questions of like, are there people that you need to be here for you? Because this can spark, some places in a person that they don't even realize they're going to go to, which is freeze mode or combative mode, whatever it is. Yeah. Um, is there anything else that comes up for people as we move forward? Okay. So I am going to move into, I'm going to share my screen again. Oh, that's the wrong one. Don't share that one. Okay. So what I've been talking about is confidence or trust. When we walk into a scary moment, it's might be hard for us to trust. trust in the people that are there, trust in ourselves. Confidence is really just trust. And when we are around people who are supposed to be there to care for us, and they don't know us, but they assume they know us, and they're going on the quickest information that they can get, which is seeing us right in front. And they're coming with their own bias, really, their own information. And bias isn't bad, but it can be pretty scary on the other side, because then we are also not only dealing with trust in the healthcare system and our health, but also trust in being seen in a certain way that maybe we've learned isn't possible or as easy. So, what I will offer you today is not only um, the slides to this, but also some question and answer, which I'll give you the link for, and we can go over it at the end if we have a little time, but also a confidence toolkit. It does require that you go to Ray Life Coaching, and I'll just give you that here.
I assume you're putting it in the chat.
Yeah.
Just checking.
Yeah, thank you. um, and so you can go there. It's just your name and your email. And what it will give you is information about Polyamory 101, which I think is crucial for people because a lot of people don't even know what that means. But you might encounter people who need who have more than one partner, who have people, I mean, or just have more than one loved one that they want there supporting them in some way. They might not even have a spouse or have a partner, but they have an extended family. A lot of people who are in LGBTQ plus have chosen family for a reason, because those are the people that see them and understand them. But polyamory is about more than one love. And so you'll get that right away, as well as a foundational materials about confidence and what I kind of talked about in regards to the familiar and how the subconscious kind of implants all this stuff. And the reason why I give that is because it helps you understand why it's important to do this work. Then the next 4 emails that come are the bias key, reprogramming of your ingrained beliefs. And then the third is about the band key and fulfilling your own needs so that you can not only help yourself, but also understand the people around you and why they're responding the way they did. Okay. And the last email that you'll get, so there's 4 emails, or 4 weeks of emails, is integration. And this just is a way to help you really integrate this learning and provide a skill that you can do as often as you want. It's very simple, but also to help you pause. Because I think ultimately, in order to stop assuming or help you, I recognize that, oh, that might be a assumption that I'm doing right now. It requires a little bit of time to see it. Okay. Before we get into questions, though, I want to share with you, let's see if I can escape here. My my questions that I will be giving you, uh, and answers. Let me see if I can get this bigger. So this is kind of similar to, oops, here we go. Can you see that now? Yeah. This is kind of similar. This PDF that I'm going to provide you is kind of similar to that idea of, when you make a mistake or realize you take that pause, you go, oh, hang on, I said the wrong thing, or oh, hang on, that might have been an assumption. And like, oops, I don't want to do that. I'm going to correct that. And saying out loud is really helpful because it holds you accountable. And also knowing your power, right? Especially if you're in a space of higher power than like I said, the that wheel that I showed you, if you're caring for somebody else, they are already in a lower space, just especially when they're scared about their health. So admitting and accounting for your responsibility in that space will definitely create more trust. So here are some questions, and I'm going to give you the link to these questions and answers. And you can use that at your will. But let's open the floor. And if you want to pull that document up, hopefully it doesn't like stop you from pulling it up. Let me know if someone pulls it up, if you can tell me if it comes up or if I have to like approve you. Meredith, is there any way that you could check it out?
Yep, I just pulled it up and it came up for me.
Okay, good. Because sometimes I'm like, maybe don't do the, thing I'm supposed to do to make it accessible.
Are
Okay.
you okay with me sharing it
Yeah, if you can.
as you go through it? Is that visible to everybody?
Yes.
Just tell me if you need me to page down or anything.
Um,
You want me to-
so if you do, actually, maybe I should provide it because do you mind if we switch share? Okay, because it might make it harder for me. You can see mine.
Yep.
Okay. So the first part of this spreadsheet or this PDF is just the questions. Some questions, they're not all the questions, right? Um, and one is for the patients, and then we go to family members and friends, clinicians or providers, administrators, possibly. And then just overall questions about bias. What if I didn't mean anything by it? This can come up, right? And I think, we worry about being there for people, but the reality is what they need and how it looks might be different from what you think. Um, and again, that's an assumption, but it's not malice. It doesn't come from any bad, intention. It's just different. And instead, it'd be like intent matters, but your impact matters too. And sometimes in certain circumstances, impact is way more important. And so if someone is responding in a certain way, it's probably because of an impact, not an intention. And most likely, they don't think that you intended it. Not at all. However, it's possible they do, mattering upon their background. So most bias isn't malicious. It's often a result of assumptions we don't realize we're making. Awareness isn't about blame. It's about increasing our ability to care effectively. And that's also for ourselves. Sometimes we get so upset about something and we know that the intent wasn't, and we might not allow ourselves to that shame about, oh, I know they didn't intend it, so I can't say anything, I can't do anything. And no, that is called knowing your limits and boundaries and your needs and being able to communicate it. And that's what I work with people on. um, so scroll through this. I'm just gonna, if you have it, there's a lot here, but I would like to open the floor to any questions. And if at the end you want me to, you know, if you have a question that keeps on arising, maybe we can find it here or answer it for you. Specifically for LGBTQ plus or in polyamorous, that would be fine because that would be helpful in this moment. Let me. So does anybody have, any questions that arise that there or fears about asking either your family member, your clinician, or your patient?
Not everybody at once.
That's all right. We can go straight to the questions because we do have like 15 minutes and we can like um open up the floor for maybe some of your own answers to these questions.
Ray, I have a question.
Sure.
This is Lizelle.
Hi, Lizelle.
Hi. Um, we've been fortunate in that our primary care physician knows that we're polyamorous and has been really supportive. But when we get to the hospital, we often don't feel as safe because we're not sure that they've have the training or the understanding. But we had a situation where I was going through surgery and being put under anesthesia, and
Mhm.
um, we weren't sure how to explain our situation to the staff.
Mhm.
Do you know if, like, we got around it, but how would you advise, like, because it's going to come up again, how
Mhm.
would you advise dealing with something like that?
Um, well, it's also access, right? Having these people available, like your family, your chosen family, being able to be notified. Is that part of it?
It is part of it, and because we have kids, my husband and my partner took shifts being available, but at one point they wouldn't let both of them back and
Mm,
to be, to be with me. So we had to pick and choose, which
mm.
you know, it was hard. So
Was that because of the number of people that could be in the room, or no? Not at all.
no, it was
Okay.
because the staff was like, well, only your husband can come back. So
Um, do you have any documents that give medical like space for your partner
we
to,
started completing them because we recognize that it's something that
yeah,
is going to keep coming up. Um,
yeah.
but like as we've been talking with medical professionals, like emergency folks are starting to look for training, but the day-to-day staff in hospitals, it doesn't seem like they have access to, that kind of training. So that
All
was
right.
my question was, do you have any suggestions on how to get that information out there?
Uh, yeah, that is hard, but I can definitely, I would say that documentation is really helpful because putting the kind of legal terms in there is, and even just saying it, maybe like, oh, I have a medical list. Sometimes that these people are my people that can help me
Hmm.
with this,
Hmm.
that it brings them up to status level that's
Hmm.
needed. But other than that, it can be difficult mattering upon the organization, and how those people have been trained. I would say maybe preemptively doing it, but again, if you're in a rush and a quick needing a quick response, having something already to the ready is always going to be the case. Maybe also knowing um, some advocates in that community, like getting connected to
Hmm.
either that hospital or like board member level. Um, but yeah, it's definitely why I'm here. You know what I mean? Like that's kind of what I do is help train people in those spaces. Um, but if I get your information, I'm forgetting your name. Who's speaking? You that
It's okay. It's Lizelle
Lizelle.
Clark.
Um, that I would definitely research that for you if there's any, because I have some doctors in the field who would give me some ideas of what would be the best thing to do in the moment, like a quick response. Because I'm thinking that that's probably what you're looking for is like how do I talk to these new people when, they're always going to tell me the standard thing that they've been taught to tell me?
Right. That's
Yeah.
very helpful. And I didn't think, which is the obvious, of looking for advocates within the hospital to help navigate. So thank you for that. But I will definitely give you my contact information.
Okay. Thank you, Lizelle. Um, is there is there anything else that comes up for y'all on the questions that come up? Or do we have about, I don't know, 7 minutes or so? Okay, I'm just going to share the questions again, and we can kind of like go through them. And if one comes up, feel free to put it in the chat, that feels like it's really relevant to your situation or to somebody that you're helping. Um, so I'll just go up to all the way to the front. Patient and survivor, identity and disclosure. Do I have to tell my doctor I'm polyamorous? We had that. When should I disclose my identity? And what if I don't feel safe telling my provider? And you need to feel safe, right? I mean, as we just heard, it's important because your relationships are important in healing. Um, and also, there might be factors that are involved. They need to talk to people. You might need to have someone be there. Thank you, Lizelle. Um, what if they keep on using the wrong pronouns? How do you address that as the person who's receiving that behavior in return? How do I decide what information is relevant to share? And really, this confidence toolkit helps that, because once you start responding to these questions and then have an emotion that comes up, it can be telling what you're really needing. And then you know how to say it, and how to say, hey, this is what's coming up for me when this happens. And I'm noticing that I'm really needing this. And this is how this looks like. I'm needing clarity, and clarity looks like this for me. Um, it's important to be able to communicate. And it's important to have people in return who can communicate with you. That doesn't always happen. And then you need to know how to set your boundaries. And that is really hard when you are dealing with health care scares, right? So, how do I speak up without becoming the difficult patient? What if I don't understand what my doctor is saying? Like Jennifer, I think it was Jennifer had mentioned, how do I ask for more time? What if I disagree with treatment recommendations? How do I ask for another opinion? These are really hard because the power dynamic may be so high in comparison, that you feel really restricted. So there's a lot of questions here. If anything comes up for you and you want to put it in the comments, I would love to talk about it just like Lizelle did. If you have people who are trans, or you or yourself are trans, or you go by a different sexual preference than you're used to, and that is affecting, maybe it's affecting your ability to um, be the same person you used to be, and your identity is changing, and that's really affecting your ability to choose what to do for your health. Okay, so family members, what should I say? What should I not say? I can see that it can be really hard to be in that situation and feel like you want to be there, but the person that is you're caring for is really having a hard time, because of their attachment style, because they're either getting aggressive, or they're getting overly chatty and very anxious, or they are just shutting down completely. I'm going to go over to, I'm afraid of saying the wrong thing. Curiosity is usually more important than expertise. And I think this is so important in general, just asking the question. Also, before you ask the question, maybe repeating. This is a really important thing to do is if you can get yourself regulated as like the bias key and the needs really help start to regulate you a little bit and be able to hear the person and what they're saying, just repeating what they said will do wonders. You'll be surprised on how hard it is actually when someone's heightened or having a hard time speaking or they're emotive, and you can say, "Hey, I heard that you said this. Is that true?" Always asking at the end, "I'm noticing that you might be feeling this. Is that true for you?" "Oh, okay, it isn't." And then repeating it back. Um, "I'm guessing that you might need this. Is that true?" They are experiencing being seen in that moment. And you are, if you're regulated or trying to hold space for yourself, as well as seeing them, then you're tuning to each other. And that creates a form of oxytocin in both of your bodies and creates a calm. So it's really important. This basic skill is so important, but it's hard. It can be very difficult when things are complicated. So even actually, Lizelle, um, in that moment of trying to advocate for yourself, that might also be a possibility, whether it be you or your partners being able to like almost repeat back what the person's saying because they're saying a no. But sometimes being able to respond back can almost open doors if you're in that calm space. Okay. I think I'm gonna stop. Let's see. Partners without. And you'll see that there's a lot of little answers, but I would love your um, input. If you look at any of this stuff and are curious, feel free to reach out to me. My email address is at
Ray, if you don't mind, if you'll send me the link to your website and the link to the document in an email, I'm going to send that out to everyone and copy you on it.
oh sure. The link is you mean this one, the questions and answers one, or
Yes.
the
If you can just
okay.
include them both in an email to me, I'll forward it out to
Oh sure.
everyone.
Oh
That way they'll
sure, I
get
can do
every
that.
way to get you. So,
Yeah, sure.
well, thank you
Great.
everyone for making the time today. I appreciate it. Thank you so much, Ray, for making the time. And I'm so happy that I met you and was able to talk you into doing this. So I will catch up with you after this. And thank you, everyone.
Okay.
Have a good rest of Thursday.
Okay. Thank you. Bye.